A slight reminder of exactly where we are based on the published literature, including a test which many of you may be familiar with, and that's the Guardant test that was published in the New England Journal of Medicine in March of 2024. And this is a cell-free DNA-based, blood-based test for colorectal cancer screening, and it's a plasma test. You get a tube of blood, you check the plasma, and in the plasma you can see that there is circulating cell-free DNA. In this study, in average risk populations, not high-risk populations, this particular cell-free DNA blood-based test had 83% sensitivity, not that, but not colonoscopy, 90% specificity for advanced neoplasia, and 13% sensitivity for advanced precancerous lesions. So it's a good test, but it's not terrific for advanced precancerous lesions. That being said, what do you do when you get a positive Guardant Shield test? You go to colonoscopy, which is a much more sensitive and specific test, and obviously much better for early precursor lesions. What do you do with a negative Guardant Shield test? Reassure your patients and repeat every 3 years, and also consider other standard technologies. That's not the only liquid biopsy technology that's available. In fact, there are other tests. The Guardant Shield test that I just described to you is in fact this blood-based colorectal cancer screening test. It was FDA approved in 2024, and it is in fact covered by Medicare. There are other tests, including multi-cancer detection tests like the Grail Gallery test, which I'll describe in a little bit more detail. That's a blood-based multi-cancer early detection test. It's cash pay. It's not covered by insurance. The cost is about $950. And in addition, I also want to highlight that there are multiple clinical trials of other technologies at City of Hope, and you'll hear more about them as we move throughout the day. Let's just think about what the Grail Gallery test involves. What's the sensitivity of the cancer signal detection by stage in 12 pre-specified cancers that are really the most common cancers that we diagnose in the United States. And we'll concentrate here on colon and rectum for the purposes of this particular study. And here what you can see is that for early stage disease, the sensitivity is not that high. For advanced stage disease, of course, the sensitivity is quite high, but here what we see is that the sensitivity of colorectal cancer screening with the Gallery test across stages 1 through 3, because you don't necessarily want a blood test to be detecting stage 4 disease if it's going to create any long-term advantages. The sensitivity is 67.1%, so not terrific for early detection of colorectal cancer by itself. But the way in which the Grail Gallery test is considered is one where we look at its ability to detect multiple cancers. So as we look at these data here, this just focuses in a little bit more closely on these data here for colon and rectal cancers in stage 1 and 2. That is 67.1%. When we use the Grail Gallery test, it's often done in conjunction with common screening options, and it is not done in lieu of those other important screening tests like mammography, cervical cancer screening with pap smears, colonoscopy, or other strategies like the Exact Sciences tests that can be done on stool testing or liquid biopsies like Guardant Shield. So when you use common screening options, you can see that the detection of the combination of Grail with other signals is quite strong, but without other common screening options, the performance drops off, especially for some cancers like thyroid cancer, kidney cancer, and other cancers like uterine cancer. There are multiple ongoing studies of Grail Gallery tests, really in order to demonstrate its clinical utility. In the United Kingdom, there's a National Health Service study of 140,000 people. The goal of that study is to evaluate whether or not the Gallery test leads to a reduction in the diagnosis of stage 4 cancers. Those results are expected later this year or in next year. And there's also a study in the United States called the REACH study. That's a Medicare demonstration project of 50,000 people. The first patient was enrolled last July, and that's a study of usual care plus annual Gallery tests versus usual care alone. So what do you do with a positive GRAIL Gallery test? You see your physician, you do additional testing that can include a variety of tests depending on the signal, including CT, MRI, or PET scan, blood tests, and often a biopsy itself. And in fact, that is something that's important to recognize because the sensitivity and specificity is not perfect. It will not detect all cancers that arise, and all those tests that are positive do not necessarily mean that you have cancer. So sometimes you can engage in a diagnostic odyssey to undertake a long and expensive evaluation for something that is not there. So you need to consider that as part of the risks, benefits, and alternatives to something like the GRAIL Gallery test. And what do you do with a negative GRAIL Gallery test? You continue to screen with approved screening, including mammogram, colonoscopy, and PSA. Now let's turn our attention to the epidemiology of immune responses. And here we'll focus not only on the meaning of immune responses to colorectal cancer, but the ways in which we can detect them, including technology involving artificial intelligence. And I'm going to concentrate on recognizing prognostic and predictive potential of immune measures of colorectal cancer. This work is based on data that was derived from one of our recent R01s. This was the epidemiology of immune responses in colorectal cancer. And here I'm just showing a figure of a colorectal cancer with beautiful tumor-infiltrating lymphocytes shown there with those dark nuclei and the halo around them. When we see them at the leading edge of the tumor, they offer prognostic and predictive information. I will also say it's actually reasonably just to count those. I see 1, 2, 3, 4, 5, 6, 7, maybe 8. But if I were an expert pathologist, I'd be able to quantify that specifically within each high-powered field that I'm looking at and then use that information to advance our clinical understanding. As we did our large population-based study of approximately 6,000 cases and 5,000 controls of colorectal cancer in Israel, in the molecular epidemiology of colorectal cancer study, we were able to publish data that showed the impact of features like microsatellite instability on overall survival. And here you see data that we published back in 2016 with Laura Rosick and Stephanie Schmidt, showing that microsatellite instability, as you are all aware, is a predictor of improved overall survival. But the question is, why is that actually true? And as this audience well knows, it's not just that it's microsatellite instability and that can lead to increased utilization of therapeutics like checkpoint inhibitors that allow us to get better responses, because remember, our study was actually done in an era before the introduction of checkpoint inhibitors. So this is really related to the prognostic advantage of microsatellite instability before the introduction of checkpoint inhibitors. And we actually asked the question, what is it about microsatellite unstable colorectal cancers that can make a difference? And that includes tumor-infiltrating lymphocytes like we just quantified. And here you can see when you set an optimal threshold at greater than or equal to 2 tumor-infiltrating lymphocytes per high-powered field, it's strongly predictive. I can also tell you that this was a real pain for our study pathologist, Dr. Joel Greenson, to do. He had to review all of those studies individually, look at the H&E slides, count 5 consecutive high-powered fields, and count those tumor-infiltrating lymphocytes. Well, we actually have another project where we're now using artificial intelligence to take advantage of the fact that this technique called deep learning is especially useful for image recognition. And I'll just introduce 2 different topics here. You'll learn more about this later from others even more mathematically sophisticated, but predicting dichotomous biomarkers. It's there, it's not there. You have more than 2 tumor-infiltrating lymphocytes or less than 2. That uses a technique called transformer-based artificial intelligence. Whereas if you're predicting continuous biomarkers, like, hey, I actually want to know how many tumor-infiltrating lymphocytes are in there on a regression-based way. Is each individual tumor-infiltrating lymphocyte offering more information? That's a regression-based model. So deep learning and artificial intelligence approaches to precision medicine are already making a large impact, and digital pathology has the potential to improve not only tumor detection and diagnosis, but our ability to recognize mutational profiles, treatment response, and survival. And here, as you get closer to the center of this target, you can see you're actually getting closer and closer to FDA approved technologies which use artificial intelligence for diagnostic and prognostic purposes. In one of our current R01s, the epidemiology, pathology, immunology, and colorectal cancer outcomes study, we're actually looking at digitized images from 6 different centers across the world. And we're taking those images, digitizing them, and I'll walk you through exactly how we estimate the information that can be gathered from each of these tessellated tiles within an H&E image. And our overarching goal is to shift the paradigm of how colorectal cancer is diagnosed, molecularly characterized through histologic, genomic, and immune features derived from routinely collected images. This has been a long-standing interest of ours, and in fact, when we first started working with Dr. Greenson back in 2001, we published our first paper that looked at what are the histologic features that let us know, hey, this could be a microsatellite unstable tumor. And in fact, as that technology evolved, we were able to develop logistic regression models that predicted microsatellite instability, and those features are shown here. Most importantly, of course, greater than or equal to 2 TILs per high-powered field, but there are other features as well. Things like moderate differentiation, Crohn's-like lymphoid reaction, right-sided location, absence of dirty necrosis, mucinous differentiation, histologic heterogeneity. Those features Joel and other pathologists can look at and say, hey, I actually recognize this as what is likely to be a microsatellite unstable tumor. And the performance of this particular model was pretty good. So it actually led to some advances for pathologists to be able to use this to predict when to conduct further workup for microsatellite instability. Of course, now we offer universal microsatellite instability testing, so you don't have to include it at that level. But we've concentrated on ways to predict microsatellite instability from H&E slides. And back in the early days, we were able to develop receiver operating curves which showed that the performance was pretty good with an AUC of about 0.80. But in fact, in collaboration with our colleagues in Germany, especially Dr. Jakob Hather, we've contributed to work where a transformer-based model, and this is detecting something that's dichotomous, like microsatellite instability, or is the tumor BRAF positive or KRAS positive. This can be done on a large scale. 16 different colorectal cancer studies were included of 13,000 patients. And the way in which this data flow works from analysis, you actually move from whole slide images to biomarker prediction with an end-to-end weakly supervised deep learning model that allows you to take the tissue, create the slides, digitize them, analyze them in a way that you'll see in just a moment through our workflow until you actually get down to the predictive models that allow you to correlate that with outcomes we'll see in just one moment. Here's the workflow in a little bit more detail. Here we look at a whole slide that's digitized. Those tissues are segmented and divided into pixels. They're put into a tessellated image function which allows us to do things like color normalization to make sure the staining's relatively equal. And then as we move through that, we can take those images and we can extract features. That essentially converts the digital images into vectors of data. Those vectors can be converted into these deep learning models which allow us to come up with predictive models that we can train. I will also say that our pathologists remind us of something important. And this is Dr. Stan Hamilton from City of Hope has often reminded me as one of our study pathologists. Steve, I wish you would use the word augmented intelligence instead of artificial intelligence. What you're doing is you're helping pathologists become better. We're augmenting our work, not replacing it. And in fact, One of the things that these techniques that we've developed allows us to do is allow a pathologist to see interpretability. What are the areas of a slide that we should be drawing our attention to, and how do they relate to one another? So as we think about ways in which we can now use these features to predict microsatellite instability from histologic images, we can not only do it from surgical resection specimens in a way that's highly accurate with an area under the curve of 0.96, but we can get clinical grade performance on biopsy specimens from external cohorts, and these are from the biopsies. These are what you guys do with the biopsies themselves before Dr. Kaiser and others have a chance to resect these tumors. An envisioned clinical workflow from microsatellite analyses of biopsies included an AI-based biomarker prediction, which allows us to do affirmative testing and also understand when some tests are so low probability they are not likely to yield important tests, and then use that for test stratification. And that can be done for genomic features as well as features like tumor-infiltrating lymphocytes. But let's get back to tumor-infiltrating lymphocytes for just one moment. And in the last 3 minutes, I'm going to present some data that we presented last year at AACR and will be coming soon to a journal near you. Here's Dr. Joel Greenson, who in this particular tumor said, I count 10 tumor-infiltrating lymphocytes per high-powered field in 5 consecutive high-powered fields. Our AI predicted model said, actually, there are 8.41 that we can predict we would see. Oh yeah, and by the way, all the good information is down in this part of the slide itself. And here, you can see that the area under the curve for predicting TILs with regression-based AI is pretty good, 0.81. What we then do is we correlate that with the outcomes of patients in our study, and we looked at what's the reality of when Joel counts them, and 5-year colorectal cancer survival is highly predicted by Joel's counts of tumor-infiltrating lymphocytes with a p-value of 0.001, and AI TILs, same exact p-value, and those curves look nearly identical. And here you can see that the number of cases that were predicted to be TIL positive were nearly identical to those that Joel counted himself. So man versus machine, woman versus machine, when you look at 20-year overall survival, we see the exact same thing. So do computers replace pathologists? No, but they certainly can augment their performance. Here in a multivariate Cox proportional hazards model, what you see is that AI predicted tumor-infiltrating lymphocytes is actually a stronger predictor of 5-year cancer-specific survival than microsatellite instability after adjusting for age, sex, and stage. And finally, in the last minute, I will conclude by talking about models for managing individuals, and specifically using a tool developed by our colleagues at Harvard, Giovanni Parmigiani and Danielle Braun, developed a model called MyLynch. And if you don't know about this model, this will be a helpful thing for you to appreciate. This is something I use in clinic for my patients with Lynch syndrome on a very regular basis. And what it allows you to do is develop specific models for the patient sitting in front of you. And let's just walk through a hypothetical example. Let's say you have a 35-year-old black woman, a non-Hispanic, who comes in with an MLH1 mutation. She has never had any prior screening. She just learned that she's positive on the basis of cascade testing from an affected relative. And she's 5 feet 4 inches tall, and she weighs 160 pounds with a BMI of 27.5. So what we can do is we can look at what is her lifetime risk of cancer, and you can actually estimate that in the following way. If there is no screening at all, if she doesn't make it to gastroenterologist for screening with colonoscopy, and she doesn't get any colonoscopy, her risk of colorectal cancer at the age of 75 is 69%. But if we take advantage of the technologies demonstrated here, including on-schedule colonoscopy every 2 to 3 years, but not adding aspirin, the risk of colorectal cancer at age 75 is 30%. And if we add aspirin, the risk of colorectal cancer at age 75 is 18%. I can tell you that these data convince our patients quite convincingly that they want to stay on track for their colonoscopies, and many of them elect to take 5 years of 81 milligrams of aspirin as long as it's well tolerated. So in summary, liquid biopsy holds promise as technologies continue to emerge with improved performance. Artificial intelligence identifies features from digital pathology to predict clinically relevant outcomes, and quantitative tools point our patients towards preventive management of colorectal cancer risk. And I think we're pretty much right on time, so I am going to reserve questions for the panel itself. Thank you very much.